All right, well, welcome back this week, everybody. I'm your host, Dr. Mark Morningstar. This is Scoliosis World. As you can see, I have a very special guest here on this week. This is Dr. Megan Strockman. She is the medical director here at the Natural Wellness and Pain Relief Center, where obviously I've been practicing for, 25 years or 24 years? Something? 23 years.
Almost 24.
Almost 24 years. And she is not only the medical director for our clinic here at the Natural Wellness and Pain Relief Center, she's also the medical director for Back Genius. She is also the executive director for our charity, Ireland's Dream. And what else?
I am the vice president of the International College of Integrative
Medicine. Yes, that's true.
I sit on the board of the American Association of Oral and Stomach Health, and I am the medical director of AMP.
Oh, yes, our IV clinics. I forgot those. How could I forget those? But yes, she is the medical director for AMP Infusions. But anyhow, obviously, all of that is to say that she's infinitely qualified to talk about what we're going to talk about today. And frankly, since I had her as a guest on this podcast before, was it a year ago or maybe a little more?
It's been a while.
It was a while. Yeah. And even to this day, it's been one of the more highly viewed episodes that I've ever done. So it only makes sense to bring her back and actually talk about a topic that's really sort of in her wheelhouse. She trained as an OBGYN, so it only makes sense that if I'm going to have a podcast episode on hormones, why not talk to somebody who does hormones almost exclusively? So, and the fact is that because I get the ability to practice with her, it's really what has allowed me to make a lot of the advancements we've made over the years in scoliosis management, especially in regards to genomic testing, neurotransmitter testing, hormone testing, etc. Because I myself, as a chiropractor in the state of Michigan several years ago, wasn't allowed to do this kind of testing. And so I had to have her help me with that in order to kind of get that part of it off the ground. And of course, it's, blown up ever since. And what's really cool is, of course, you guys probably don't know this, but, before I met Dr. Strockman, I was like a single-celled organism. And then she pretty much kind of turned me into the man I am today. And so we're going to have a nice, friendly, fireside chat here in our office about hormones. And like I said, it's a very popular topic, very, very germane to the field of scoliosis management for a variety of reasons. In fact, there is so much that we're going to talk about that we decided that we're actually going to make a 2-part episode. And so today will be part 1, where we're really going to focus more on how hormones affect children or adolescents, and why they impact the onset and progression of scoliosis. And then in part 2, we'll kind of go through more onto the adult side of things, how hormones affect adults. We'll talk about, childbearing, perimenopause, postmenopause, all of and how those stages interplay with a scoliosis curve. And more importantly, how they interplay with a variety of symptoms or what we call comorbidities in patients who have scoliosis. And so we're going to hit on a lot of those topics here today and in the next episode. So welcome to the show.
Thank you for having me.
All right. So I think the first thing that I would like to talk about is, and this is something where, and I hear this a lot because, again, a lot of, especially young females who are diagnosed with a curve are still probably seeing an OBGYN conventionally, and especially if they're having hormone symptoms. Well, and we kind of talked about this already, before the show, and
What age are we talking about when you say my young?
Meaning 13 to 16.
They're not seeing OB yet.
They're not seeing OB yet.
No.
So then family practice.
Not usually. Yeah.
Family practice then would have put them on birth control pills to help regulate hormones. Is that fair?
That's possible, yes.
So speak to us a little bit about, if you would, about oral birth control pills and why they're not a good idea, what they do, why they're not a good idea, side effects, and what are some alternatives potentially for that age group.
My utter dislike of birth control pills?
Yes.
Okay.
Yes.
So we always have these jokes about what script you could write out for a different physician in different types of specialties if you had to just make a entire prescription pad with the thing they use all the time. And for OB, it's always birth control, right? Here, everybody gets some birth control. And I detest that on many levels. The first level that I detest it on is the fact that it then turns everybody into the same person. Everybody's the same person and they just need birth control pills, right? Which is so untrue. Second of all, birth control, let's talk about mechanism of action for birth control. How does it work? First and foremost, it, through different levels of pills, of synthetic hormones, at different stages in the woman's cycle, it stops them from ovulating. That is the first mechanism of action, right? Is for them to cease ovulating. The backup to that is to make, I guess, to put it in layman's terms, is to make the uterus inhospitable, right? So that it is more difficult for implantation. Because many of you out there might not know this, but fertilization actually occurs up in the tube, not down in the uterus. I know most people actually don't know that, but that is where fertilization occurs. And then it rolls down into the uterus and implants on the wall of the uterus. Rolls down the tube and into the uterus. So those are the two ways that it works. The problem that I have mainly is that I don't like the inflammatory properties of birth control pills. Because they are synthetic, they have properties very unlike your natural hormones that you inherently have in your body. And the inflammatory risk that they carry can cause long-term effects down the road. There have been a lot of studies, many of them European, talking about risks and believed to possibly increase the risk of breast cancer, believed to possibly increase other types of cancer, although being stated that it can lower the risk of ovarian cancer in the future. That is just from lack of ovulation, likely. So, in my opinion, in a world so full of hormone mimickers, the last thing we need to do is fill a child's body with synthetic hormones. And that kind of takes me off onto a tangent. Is it okay if I discuss environmental, or do you want me to?
Well, I mean, I was going to get into that, but I mean,
okay, I won't digress then. I will continue on my road of I don't like synthetic birth control pills and what to do instead. Is that what you?
Yeah. So
okay.
I mean, obviously, if I'm a parent of a child who comes in to see me, for example, for scoliosis management, and because I have a great many scoliosis females who come in here on birth control pills and they're in their early to mid-teens, and they, when I ask them, it's obviously because they were having irregular periods and that's why they were put on them.
Right. Which stems from hormone disruption.
Right. And of course, not necessarily every parent, but a lot of parents have the same question coming in, which is, I don't really like that my daughter is on oral birth control pills, but I don't know what else I can do to solve how my daughter, her acne or her painful periods or her irregular periods or all these reasons as to why she was put on oral birth control pills. But I wasn't presented with any other option.
So you're gonna force me down the environmental pathway then. Okay, so that being said, what is important to understand is that the world we live in is a very dirty world. We live in an incredibly dirty world.
For sure.
Full of hormone mimickers, okay? Hormone mimickers come in many shapes and sizes. When I speak of hormone mimickers, one of the biggest ones, it's an estrogen mimicker, is glyphosate. Glyphosate, otherwise known as Roundup, which is the stuff they spray all over your food if it's not organic, and you might take a little pack and go spray your lawn with it. It is in everything. It is in every single thing you eat, unless it's organic. So
and BPA.
And BPA. And BPS. I can go on and on. There's so many hormone mimickers. There are so many. There is stuff in our air. You know, there are tons of birth control metabolites in your water if you have city water. They've done studies to show how high of a content you have. Now, I've not looked at studies where the person had reverse osmosis. If they had a RO filter on their water, if it still had hormone metabolites in it. I thankfully have a well and grew up on a well and have really only had to have city water for short amounts of time in my life. And I'm very thankful for that because after seeing all the studies with all the hormones in the water, that made me really nervous too.
Right. So to put that another way, just if you didn't catch that, so a whole lot of women in this world are on birth control pills, which are mega hormones, right? Especially for human size. Well, obviously those women are on oral birth control pills, go pee, and they pee in the toilet. And where does that pee go? It gets flushed down the toilet and back into the public water system. And that water treatment plant does not have the equipment to fill out all of the excess hormone and hormone metabolites that woman peed out into the toilet. So that hormone metabolite is getting recycled back into our water supply. And everybody who's got city water is drinking hormone metabolite.
Yep. 100%. Yeah, and it's really really gross. So those are several problems there. On top of it, you are dealing with, again, the things in the air, all the plastic. Everybody's always eating out of plastic. Everybody is always styrofoam. You know, people microwave things in plastic. People use the microwave and stick these containers in there that are
TV dinners.
Yes, that are just gross. And all of these things lead to chemical disruption in your body. So when I get a patient in who is young and they have hormone disruption, I will run these levels on them. I'll run glyphosate on them. I will run chemicals on them. Sometimes heavy metals, depending on, possibly what they're presenting to me with. And I always see some really interesting things with their results. So also the conversion of their hormones due to external effect. Sometimes their acne is from that. Their estrogen. You have three different kinds of estrogen. You have estradiol, you have estriol, and you have estrone. Estrone is your predominant postmenopausal estrogen. It's quite inflammatory. Back in the day, they used to replace it because they didn't really know better. And so if a woman was on bioidentical hormone replacement, she would take something called Triest. And Triest had estrone in it. We don't use it any longer because we figured out that it is very unnecessary and, as a matter of fact, probably not even a good idea to replace estrone. So we use Biest now, which is estriol and estradiol. Estradiol is your most predominant estrogen when you're young, prior to menopause. And it is a very active estrogen. Estriol carries great anti-inflammatory properties, but its half-life, meaning how long it exists in your body, is short and quick and kind of sweet and to the point. So with a woman a young woman who's having acne problems, you want to look at their conversion, their estrogen conversion, and see what that looks like. Do they have too much estrone? Sometimes they do. You want to look at their heavy metals. You want to look at you want to look at all the chemicals and all that stuff. Those are big things for me. What is disrupting them? Because the birth control pills might make it seem better because it's giving them these bursts of synthetic hormone that then suppress their internal hormones, and it makes it feel better, whatever's going on, their heavy periods, their heavy cycles, their acne, their cramping, their heavy bleeding. It might make them feel better, but it's actually not making the situation better. It's not fixing anything. It's covering it up and possibly making a bigger mess.
So then what's the best way to determine? So obviously if a patient comes in and they're already on oral birth control pills, with everything that you just said as far as estrogen conversion goes, well, how do you reliably test for that laboratory-wise?
So there's a few different ways that you can test. In young women mostly prior to like 35 to 40 years old, depending on the case, of course. It's nothing set in stone. I do a month-long salivary test, which will check their estradiol and their progesterone. And it's nice because remember, your hormones fluctuate all month long, right?
Sure.
They don't
Sure.
just stay the same all the time. You don't have this just like even keel. So as your estrogen and progesterone flux, you want to take a look and be able to see the test that I do. They take a sample every third day. So every third day they plot it on a diagram, and you can actually watch the chart and see how the person does estrogen and progesterone wise. It also checks their testosterone, but honestly, testosterone is best checked in the blood. It's not as accurate in the saliva, they've shown. So that's how I do it with my young kids.
But even if they're on oral birth control pills, then the testing will still be accurate.
Not always, no, because they have suppression of their hormones. So what I do is I will still look at that test. I'll still use it on them. But you have to make the side note that there could be suppression, and there likely is suppression due to them taking hormone pills. And then you have to look at what they're taking. There's so many different kinds of birth control pills. It's not even funny. There's the ones that don't allow you to have you don't have a period for 3 months. They're high dose or low dose. There's a lot of different ones. So you have to take that into consideration too. What kind of birth control pills are they taking? It's much easier if they're not on them. And I have many patients who've come to see me and they say, you know what? Actually, I've been wanting to get off these anyways. This is the perfect time, I guess. So they go off of them to test so they can get a more accurate picture.
So if they want to go off of them to test, how long would they need to go off of them in order to test?
I have them off for at least a month.
Okay.
There's still some effect. We all know that when a woman goes off birth control pills, it takes months and months to regulate. But these people are wanting an answer. So really to keep her off of birth control for, 3 months and then have her test it's a pretty hard thing to ask for when they're that miserable.
Sure.
So what we'll usually do, I'll give them a month, and then with their next cycle when it starts, I'll have them do their salivary testing.
Sure. So then in my mind, then it would make sense that because it's so hard to test and get a very good clinical picture when somebody's on oral birth control pills, that maybe the better route in the beginning is to look for, okay, do I have genomic predisposition towards certain hormone problems? And or combined with, do I have certain environmental exposures and accumulations that might also be driving the initial need for birth control pills? Mm-hmm. And in the process, address those things. Yes. For 3 months, 6 months, something like that. Mm-hmm. And then when we've shown that those reports have improved, then maybe it's an easier conversation with the patient to say, okay, now we want you to be off the birth control pills for 90 days.
Right.
And maybe even at that point, maybe they don't feel as bad as they did.
Sure.
Because now we cleaned up all the junk that really spurred a lot of these hormone problems to manifest.
And sometimes too, and again, medicine is that's why we call it practicing medicine. There's a lot of wiggle room and a lot of different things. I've been in practice for I don't even know anymore, almost 20 years. And so
04, so
yeah, something like that. It's still a long time. And
well, after residency. So what? That would be
anyways.
07, 08.
Anyways.
So 17 years.
So for me,
yeah,
what's most important is it's on a case by case basis. So when it comes to a kid, you have to meet them where they're at and then work from there. And I know that for me, some of them I can take them off their birth control, wait for them to get their cycle back. Like some of them don't cycle. Wait for them to get their cycle back, and then sometimes try pregnenolone. Pregnenolone's a precursor to progesterone. And sometimes I've been doing this so long that I can, just from the history and what they're telling me and what this started with and how this happened, I can tell that they were estrogen dominant, meaning they had a lot more estrogen than they had progesterone. And why that matters, progesterone and estrogen balance each other out. They belong together. They're buddies. I always tell everybody. They work synergistically, and progesterone is I always I always tell my patients this is my like little scenario. Estrogen builds up the endometrial lining, and so think of like some guy chopping wood, and then progesterone organizes it. So think of the guy throwing it to his wife, and she grabs it and stacks it and makes it a nice, neat pile. So estrogen is going poop, 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 and then progesterone's going, okay, make this neat. Well, a lot of times if they tell me they had really heavy, crampy, painful periods, their progesterone was low and they were estrogen dominant, likely because of mimickers, mostly. And so sometimes you can start trying to get them feeling better with some pregnenolone. You just have to be careful with that too, based on body weight and just like how the patient presents to you, because if you give them too much they'll be tired.
Sure.
And they'll
Sure.
spot in between periods. So there's just a lot of finesse to it, I think.
Well, so that brings me to another aspect of that then. So, in scoliosis, obviously, most children who are diagnosed with scoliosis actually have very, very little body fat, or at least far less than their peers. And however, even despite their lean body habitus, I'm noticing more and more and more that a lot of kids have hormone issues who also seem to have insulin sensitivity issues. So if you wouldn't mind, kind of go through how insulin, or insulin resistance more accurately, interferes with hormone processes or hormone signaling, hormone metabolism, and things you might look at in the younger crowd, the younger patient base, in order to fix that.
So the running joke around here is if you go and see Dr. Strockman, she'll make you change your diet. It's inevitable, which is funny. I actually read that review about myself one time and laughed hysterically because it's likely true. The problem in our society is that we have a junk food, horrid diet thing going on that it just doesn't seem to be getting better anytime soon.
Sure.
The
kids menu everywhere.
Right.
Yeah.
And I used to sit when my kids were younger. I would sit at their dance studio and watch the kids filter in, and it was later in the evening and they had their Taco Bell bags and their KFC bags and their McDonald's bags, and it just gagged me because at home I am not perfect, but we don't do that ever. And at home, whatever I was making for dinner was waiting for us because I had it either ready to go in the oven or it was whatever. I'm not perfect, but I do what I can to make sure we eat at home as much as possible. And these kids, here they are with their really disgusting diet. Well, just because a child isn't chubby doesn't mean that they don't have an insulin problem, because our diet, people always talk about, this is my favorite example, people always bash McDonald's and they're like, oh, the fat. It's not the fat, it's the sugar. The bun, the condiments, the fries, the pop, the whole 9 yards. It's the sugar.
Pink slime.
Pink
slime in the burgers. Yeah.
That you pay a lot
food,
for
quote
now.
unquote.
Yeah. And so the problem being that we're seeing these generations of kids now that are they're all overweight. Well, PCOS, which is a term that I'm sure many of you know, polycystic ovarian syndrome, is when women, instead of getting a follicle on their ovary and then it rupturing and the egg coming out, they get a bunch of follicles. And it ties into, it's a very kind of complicated way that it all ties together, but it's insulin resistance that does that. And what happens is after years and years of consuming too much sugar, too many carbs, simple, complex even, after doing this, the body gets to the point where all the insulin's like, hey, I've run out of room, and and your insulin levels keep rising in order to deal with this huge sugar content that you keep throwing at it, until finally your insulin gets so high it just can't do it anymore, and you have desensitization to it, and then your testosterone through an it's a complicated, and the process, but it's through adrenals and it all ties in together. I won't bore you with the biochemistry, but the testosterone will rise. And then you'll see women with like a little mustache, or,
Sure.
they'll have, it's called hirsutism, where they get the hair where they shouldn't. And they're infertile.
Like basically like male pattern baldness kinds of symptoms.
Yep, they get hair thinning and they're infertile. And it's terrible. And that really right there is a problem in and of itself, because the testosterone rises and it throws off their other hormones in response. So, and on top of it, like then their LH and FSH are crazy. There's a multitude of problems. I guess my point is we really need to rethink our diets in this.
For sure.
Country.
Well, it's even when we do, so in Back Genius, when we do lab testing, hormone testing on people, young girl, teenage girls, we'll find that their hormone cascade will look mostly okay. I mean, they might have a little bit of low progesterone or a low progesterone to estradiol ratio, but their DHEA will come back high. And if their DHEA comes back high, just like Dr. Strockman was talking about with elevated testosterone, well, the reason why their DHEA is coming back high is because their testosterone is also eking up towards the high end of its normal range. And so they're getting retrograde increase of the substrate materials that get converted downstream into testosterone, DHEA being the primary one. And when we see elevated DHEA on a hormone result, especially in a teenager, we instantly think insulin resistance. And so follow-up testing on that is always necessary, whether it be through checking, and you can run something called HOMA, which stands for the homeostatic model of assessment for insulin resistance, which is a blood test, and it's basically just taking your fasting insulin times your fasting glucose divided by, I think it's like 405 or something like that. Which it's a calculation, but it tells you right then and there if the patient is insulin resistant or not. And if that's the case, really above all else, in addition to the environmental components that she was speaking to already, those are the things that you have to tackle if you want any hormone problem to resolve on a lasting basis. Otherwise, you're just going to get in this cycle where that child's now going to become adult and they're going to need to go on hormones at an earlier age just to maintain normal function. And now, depending on the kinds of hormones they went on, and of course, we're going to kind of get into this into part 2 of this podcast more in depth, but there is a big difference between what Dr. Strockman was just identifying with bioidentical hormones versus a lot of adult patients who just get put on conventional hormone replacement therapy, which is fraught with side effects and risks. And so I think at least in teenagers, I think one of the big takeaways from today's podcast is, first and foremost, check the genomics and the environmental issues that are typically leading into hormone problems, especially at a younger age like that. And then B, once you figure out what those hormone tests are, like as an example in Back Genius, we run what's called a urine comprehensive and toxic elements test. We use other labs that will check glyphosate, that can check all kinds of different chemicals like organophosphates and porphyrins and parabens and all kinds of junk that you can test for. And if you have elevations of any of those, well, then obviously it becomes up to us or doctors like us to help detoxify that person and to develop strategies to best eliminate that stuff from their system. And then maybe some of their hormone problems resolve themselves and they don't actually need hormones. Right?
Change your diet.
Change your diet. Don't eat at McDonald's. Don't eat off the kids menu, especially for we're talking about teenagers. I don't know how many kids. In fact, I just had one this week. I think she was 20 or 22 years old, still living at home with her parents, which, is fine. She's going to school, trying to, get ready to go out on her own. But she tells me, she says, I eat buttered noodles and I eat chicken nuggets. And that's what she eats basically every day. Well, I mean, depending on the kind of chicken nuggets you're eating, I mean, there's like 30 ingredients in chicken nuggets. And buttered noodles, I mean, has about as little nutritional value as you can possibly have.
Right. You're supposed to eat to live, not live to eat.
Right.
There's a distinct difference.
For sure on that. And now, fixing that, unfortunately, it's one of those things I always tell parents, it's as easy and as hard as that. The fact is, it's doctors like Dr. Strockman that tell people, look, you have to change your diet. Nobody wants to hear that anymore because everybody intrinsically knows that they eat terribly. But nobody has ever been actually taught how to meal plan, how to meal prep, how to meal schedule into your day. Because there are many ways that once you learn how to do this, it's not hard. I mean, and you know, that's maybe a little bit glib me saying this, being that I'm married to her and she might have a crock pot on the kitchen counter in the morning, knowing that that's what dinner is going to be. But that's all planned. That takes planning. That takes education to know how to do that. That's not something that you just, you know, grow up and know how to do. You have to be taught that. So I feel like a lot of what she does, especially on her side of our practice, is really spent with teaching people life skills in that way, in a certain sense, just so that they even have the opportunity to change their diet. But I agree, it's an absolutely necessary component of getting healthy and, more importantly, staying healthy. So, any final thoughts?
No, I think we ran over.
No, we're good. We're good. We try to keep it about a half hour. So
I knew I could keep going for another half an hour, but I think everybody out there is...
Well, we are going to keep going on a half hour. That's a great plug for part 2 of our next podcast for hormones. And heck, at this rate, maybe we have a part 3, 4, 5, depending on how popular they are. But like I said, the next part 2 of this podcast episode on hormones, I want to kind of dive back in with Dr. Strockman on, okay, so we found a hormone problem. Aside from diet, what are some of the things that can be done about it? And more importantly, how do we apply a lot of this information, not just into the adolescent or teenage scoliosis community, but also the adult scoliosis community? Because now we have another host of factors that kind of feed into the adult community, like childbearing, perimenopause, postmenopause. And now we have to consider factors like bone density demineralization and all these kinds of things that are also largely hormone driven. And it's not necessarily enough to just replete hormones or balance hormones, because once those hormone problems have caused enough other tissue destruction, you have to do something about it, right?
I'm sorry. I'm just cracking up. Earlier today we were watching a podcast of Ireland when he brought her in here, and I just was thinking about Ireland being over here. I'm sorry.
No,
she was cute on camera, and I just got a flash in my head about her sitting here, and I thought I should harass you like she did, but I won't.
Right. All right. Well, we thank you guys for tuning in this week. I appreciate it. I'm Dr. Mark Morningstar, obviously your host. Thank you to my bride, Dr. Megan Strockman, for coming on and doing part 1 of the hormones.
Absolutely.
And I hope you guys tune in for part 2. So thanks a lot. We will see you next week.